So anyway, I'm delighted to have David with us today. He's new to this group. Please make an effort to say hi to him. I'm not sure he knows anybody in this audience. So the more people that he can meet today would be great. Yes. He's going to talk to us about a recipe for fertility preservation.
Thank you for that very kind introduction and the offer to come and speak with this group. This is a rare treat for me, and it's nice to get a. I'm usually talking to clinical groups, and we talk about the mundane nuts and bolts of what we do, and it's very nice to talk to a group that has such breadth and interest as you all do, and so the treat is absolutely mine. And I thank Dr. McLaren for introducing eggs. This is tremendous, and that sets the stage for what I want to talk about. What do we do with eggs when we have too many of them, or we want to preserve them so we can use them later on? And egg cryopreservation is like anything, particularly in the infertility world. There are two opposing camps. If you'll look at the literature or talk to people, there's one camp that says you can't freeze eggs. It takes 100 eggs to get one good one. It's not worth trying. We're just not even close. Then there's the other camp that says, oh, no, it's here. It's in prime time now, and we should be offering it commercially to anybody we can talk to. And again, like anything in the fertility biz, the answer probably lies right in the middle. I think egg cryopreservation is here, and I think it is possible to be very effective. There's still some problems that need to be worked out, which I'm going to address today. Now, the first question is, why do you want to do oocyte cryobanking at all? And there are a multitude of reasons, particularly in the infertility world, that have been a driving force behind creating a system of freezing eggs. First is to avoid embryo cryopreservation, and there are a lot of moral and ethical issues that are surrounding general IVF, where you create more embryos than you need to use for a fresh embryo transfer. People have thoughts about not wanting to have embryos frozen. They think of these little souls or little babies that are in liquid nitrogen, and they don't like that concept. And if you could freeze eggs, you could avoid the abundance of embryos that are frozen. Another situation would be if an individual is undergoing a risk of ovarian failure, ovarian failure, and this comes up with cancer patients that are going to go through gonadotoxic chemotherapy or radiation therapy to render the ovaries sterile. If you had the time before her cancer treatments to get eggs from her, you could preserve them so that when she went into remission, which is becoming more and more common now, she'd have an opportunity to have her kids down the road. Certainly reproductive aging comes to mind. People that have the wherewithal that they're going to be entering into a professional career or something like that, and they're not going to be having children until they're perhaps in their late 30s and 40s, and they want to avoid the consequences of reproductive aging, come to us when they're 20, 25 years old and say, let's freeze some eggs for the future. So when they're 40, their eggs are still 20 or 25, and they have a better chance of succeeding. And certainly with our situation of egg donation, egg donors in the United States or any place actually are very hard to come by. If we could freeze the oocytes from a given egg donor, we would be able to spread her oocytes across a multitude of cases and do more egg sharing, like Professor McLaren talked about, and help address the issues of a lot more infertile couples. And then certainly for this group here, if we had an opportunity to efficiently freeze oocytes, you might have an abundant reserve of eggs for stem cell production, depending upon how you wanted to do it. So what should we freeze? And this is an important question. When we get oocytes from a given patient, they can be in two phases, depending upon the type of stimulation that the patient's gone through. They might be in the germinal vesicle stage, prophase 1 of meiosis, or they might have matured to or be maturing toward the second metaphase and getting ready for fertilization. Well, clearly for the freezing biz, if we could freeze oocytes at the GV stage, life would be easier because these oocytes structurally are a lot simpler than a metaphase 2 oocyte. Some of the problems that I'm going to talk to you about freezing are not a problem with GV stage because the nucleus is in a better condition to be frozen. However, the situation that we have in clinical medicine right now is that the GV stage oocyte is almost impossible to work with. Yes, there are some protocols coming out there and methods to try to mature GV stage human oocytes to competency in vitro. Right now, though, it's not ready for prime time. So I can tell you that for freezing, right now, the focus is on the second metaphase, the mature oocyte, the egg that's getting ready to be fertilized, the one that's also the most sensitive to some of the freezing insults that we're going to be introducing it to with the process of freezing. So what are our challenges? The biggest issue with the human egg is that it's a very large cell. And in fact, if you look at it with regard to the surface to volume ratio, it's the biggest cell in the body. And this creates enormous problems for manipulation of the water content of this large cell. And that's the key with freezing. So you don't want to have ice forming inside your cells. You don't want ice disrupting the cell architecture and disturbing the cell functions that you are so important to the fertilization process. And it's got size, it has compartmentalization. There are different domains within this cell that are exquisitely sensitive to the freezing insults. They're sensitive osmotically. The cytoskeleton, which comprises largely in this stage of the egg, the meiotic spindle, is a very big importance that I'm going to get into. And many, many other issues here that we have to address to be able to successfully freeze and thaw this cell so it's capable of not only living but also being functional. So our issues with freezing is cryopreservation damage, or we call it freeze or burn. What happens with this? Intracellular ice formation is not something we want. Ice crystals forming inside any cell or even outside any cell can theoretically cause shearing damage. Disruption of protein matrices, any potential disruption of any structure inside the cell. And ice formation is a very, very strong event. The structural forces of an ice crystal that's growing are enormous, and they can tear a cell apart very, very easily, even if the ice crystal is not very big. And the other issue is the balancing of the osmotic balance inside and outside the cell. When we go through a freezing process, the osmotic balance of that cell is changed by virtue of ice forming around it and water being drawn out of the cell. And so we want to be able to manage both of these situations as best as we possibly can to keep the cell viable. Oops, I have to go backwards on that one. Nature has solved these problems to a large extent in a very large variety of ways. If you look at animals in the Arctic or high superalpine regions and so forth, there's a lot of different animals that have the ability to keep from freezing during their cold weather periods. In the case of the Arctic animals, it's cold all the time. And if some of these animals didn't have protection while they were living underneath Arctic ice or Antarctic ice, they would be freezing. And so they've used many different strategies, including large molecular weight molecules and special proteins to manage ice crystal formation inside and outside of their cells to keep them from freezing and essentially killing them. These biological antifreeze glycopeptides are amazing molecules. They actually can cap ice crystals inside of cells to keep ice from proliferating in the cells, to keep the animal alive during its frozen hibernation period. And there are also incredible efficient hysteresis proteins that are capable in some of these animal cells from preventing any ice formation at all. And if we were able to actually recreate the production of these hysteresis proteins efficiently, we actually might have another tool to work with I'm going to skip by that, to work with for cryopreservation, but we can't do that right now. Currently, our most prevalent cryoprotectants that we are looking at with use for frozen eggs, frozen sperm, frozen embryos are these four right here. And it depends largely on the type of, I call them recipes that you're going to use as to which one of these might be more effective for the type of cell that you want to freeze. For our purposes, we're going to focus here on DMSO and propane diol, which have been utilized for oocyte freezing more prevalently than just about anything else. The issues with these, even though these molecules are similar to some of the natural compounds that animals have been using for protecting themselves from freeze or burn, there are toxicity problems. There's indirect toxicity, which essentially these molecules cause osmotic gradients inside and outside the cell, which can be damaging in and of themselves. And some of them, if they're at high enough concentration, can produce direct toxicity. They can alter cytoskeletal arrangements. They can change membrane potential. They can alter metabolic properties. And these things, again, have to be managed by the correct use of the cryoprotective agents to give your cell maximum survival. So what are we trying to do, really, with freezing? Clearly, in the perfect world, we'd like to take the cell, dunk it in liquid nitrogen, and freeze it. Done. Okay, that would be grand. But other than with regard to what's called vitrification, which I'll get into in a minute, we're talking about controlled rate freezing. a very gradual, careful manipulation of the cell's water content and external temperature gradient to keep these cells alive. So if you have a cell like this one surrounded by water and you incorrectly freeze this thing, you freeze it too rapidly, even though there are cryoprotectants around, you will get ice formation inside and outside the cell, and the shearing forces are dramatic, and it will kill that cell in almost all cases. You can go to the other side of the coin here, and you can freeze things too slowly. Yes, by doing things very slowly, you can have the cryoprotectant help draw water out of the cell, and also the freezing process draw water out of a cell. However, the osmotic gradient gets too big. Too much ice is formed outside of the cell before it begins to actually freeze in itself, drawing more and more water out so that you get a very severe osmotic gradient problem, disruption of the protein matrices inside the cell, and cell damage. So we're clearly looking for the middle of the road. Optimal cooling where internal and external ice is formed at the right speed. We can keep the osmotic balance appropriate so that the cell metabolic processes are going to be intact when that thing thaws out down the road. And this is what we're shooting for. And so all of the experiments working on frozen eggs have been trying to get the optimal situation so that this event occurs here. Keep the cell alive, keep it functional. And the human egg is more difficult than other cells, as I mentioned to you. It's a very large cell. We want to be able to get the cryoprotective agent into the cell to help move water out of the cell at the same time, introduce extracellular ice so that as the ice begins to form, it creates an osmotic gradient. The solute concentration increases. It draws even more water out of the cell, but not too much, and eventually allowing you to freeze the rest of the matrix, proteins, lipids, etc., in place, intact, and functional. Well, a lot of people have thought about freezing oocytes for quite a long time. In 1958, the earliest phases of looking at this, mouse eggs were cooled and rewarmed. They didn't freeze them. They dropped them down to super freezing temperature, generally around 4 degrees or a little bit lower than that, and brought them back, rewarmed them, and at least with the systems that they talked about here, they said the eggs were functional. They were able to undergo full meiotic maturation. There was a question.
Yeah, David, sorry.
That's all right.
How do you distinguish between damages that occur as you cool and freeze the egg versus those which might occur as you thaw it out?
That's an extremely important question, and with controlled rate freezing, that is the key. Yes, I talk about damage during the freezing process. What I'm actually talking about is damage during the entire freeze-thaw cycle. You can get a lot of cells to freeze intact, drawing some water out, getting cryoprotectant into them or whatever. But when you thaw them out, you're recreating a temperature gradient again. And actually, ice can then start to form during the thaw. And it's counterintuitive to a degree. But ice can form during the thawing process. As water is being reintroduced to that cell, it begins to warm up, water comes in, gets to cold regions, freezes, creates more ice crystals, damages the cell, and so actually the cell dies during the thawing process, not during the freezing process. So what we want to do is create a situation so when that warming takes place, the amount of water that's in the cell is controlled by the cryoprotective agent, and the rapidity with which water gets reintroduced into that cell is controlled so that there's not an abundance of ice crystal formation during the thawing process. Stan Lebo was tremendous in getting some of our earliest understandings of how egg cryopreservation might take place. He made some very nice discoveries about because of the size of the cell, some of the gradients that are important to create survivability and so forth. And some of the fundamentals that he created for freezing mouse eggs are still in use today. And so on the experimental front, by 1977, the first live births of frozen oocytes were occurring using the mouse. DMSO was the cryoprotectant, and they used a controlled rate freeze that I'll describe in detail in a minute. Their survival rates for these oocytes were not great, but clearly some of the oocytes that were going through the freeze-thaw process were functional, and they were able to create live pups. So I want to digress for a minute here and talk about an area of the freezing process that actually is probably one of the most important things. It's one thing to keep a cell alive. It's another thing to keep it functional. And since we're dealing with second metaphase oocytes, we're dealing with an oocyte that has a very large meiotic spindle in it. The meiotic spindles are exquisitely sensitive to temperature, and it is a source, probably the primary source, of potential cryo damage. And in a simplistic experiment here, if you take a human oocyte and at a second metaphase and fix it and stain it for tubulin at 37 degrees, this is a kind of a crude picture, but this is what the meiotic spindle looks like, just the tubulin matrix of that spindle. It's a barrel-shaped structure, looks like a meiotic spindle of a lot of different cells. If you cool this oocyte, even just to 30 degrees for 2 minutes prior to your fixation and staining, that matrix is disrupted. The microtubules in that are beginning to break down, and the structure of the meiotic spindle it's such a way that it's not able to keep the normal orientation of the chromosomes and the overall spindle structure. And so if we're going to freeze something, it's going to get cold. This type of thing is going to happen, and it needs to be prevented as the best way possible. Susan Pickering looked at this in a lot more detail than that crude experiment I just showed you. And using human oocytes, she found that transient cooling resulted in irreversible loss of normal spindle architecture. And a lot of us actually thought this was true, that if you took a human oocyte down to a temperature where the meiotic spindle was able to be depolymerized, that you couldn't get it back. We were thinking that the human oocyte was terminally differentiated, that its centrosomal matrix was not capable of making a new spindle if you destroyed the first one. And fortunately for us, that actually is not true. But let me tell you a little bit more about the structure of the human spindle, just to give you kind of a gestalt about how complex this structure is. It's more than just a simple cage holding chromosomes. The human meiotic spindle is an absolutely beautiful structure. And here's a series of micrographs from a single meiotic spindle in a human oocyte. And the chromosomes are aligned on the metaphase plate like any spindle would have, surrounded by microtubules that have distinct domains of microtubules reaching out, attaching themselves to distinct domains of chromatin. And if you look at this in more detail, again, this is a human oocyte meiotic spindle, and if you look at one pole versus the other pole of this meiotic spindle, basically we're looking up here, down here, very distinct nucleating sites of microtubules are reaching out to specific regions of the metaphase plate to hold chromosomes in place. It's not a random process by any means. And the centrosomal domain that's here, this is the machine that actually can create this meiotic spindle in the first place, is also a complex structure. A lot of the aspect of this centrosomal domain is not fully understood in the human. The human does contain some of the normal components that you find in a centrosome of a somatic cell, for example. Human has all three types of tubulin. It has some of the pericentriolar proteins. We don't believe that it has pericentrin, but it has versions of that. And the cyclins, of course, that are going to be operating to keeping that spindle structure operating at a normal pace. All of these things have to maintain themselves in appropriate orientation to be able to make a spindle. And also, just a quick mention here, the metaphase plate in the human egg is not a simple smear of chromosomes. It is a concentric arrangement of distinct domains of chromosomes. And we believe actually that specific chromosomes are placed in specific locations on the metaphase plate during meiosis in the human egg. Again, a process that needs to be maintained. If you're going to go through a process that takes away the spindle, you want to keep that architecture such that the spindle doesn't get disrupted and aneuploidy does not result. So if we're going to freeze things, we're going to lose this matrix. You cannot prevent the microtubules from disassembling. They're going to disassemble. But we want to be able to maintain the centrosomal matrix so that when you thaw this thing out, you don't want to have ice disrupting the arrangement of the centrosomal domains, the metaphase plate, so that when the motor comes back in place to allow the final segregation when fertilization takes place, you want to be able to get that normal architecture back. Now, we've had an opportunity to take a look at the human meiotic spindle recently in real time, something that we haven't been able to do before. And a lot of this work comes from the work of David Keefe using the pole scope, where we can actually image the meiotic spindle non-invasively. We don't have to stain the cell. You can look at it real time. And what he has shown, wonderfully, is that if you take a human oocyte at 37 degrees, where it has a normal spindle architecture, and allow its temperature to decrease, you can see that the spindle architecture, the tubulin, begins to dissolve. And if you rewarm this cell, the spindle returns. clearly, experiments like this and others that we have done in different ways and so forth have shown that the meiotic spindle is not terminally differentiated in the human egg. It is capable of bringing its architecture back into place if the machinery is there to be able to do that. And it's important, obviously, that these eggs have spindles in them. If you don't have a normal meiotic spindle present, you can get fertilization just fine. The egg's viable, quote, viable, it's alive. You can get fertilization, you can get early cleavage, actually. But the ability of that cell to form a normal embryo is dramatically compromised if the spindle is not in place. And this has to do with aneuploidy, most likely, that's causing an imbalance in chromatin distribution in the cells. And pregnancy rates are also affected by the presence or absence of normal spindles. And what we have here are 3 different systems that David Keefe developed, looking at temperature gradients and loss of spindles in cells. Those cells, essentially, that the eggs that had spindles intact had the highest developmental potential and pregnancy rate versus those that didn't. And so clearly the spindle is something that we want to maintain. So the potential effects of cryopreservation on the human egg are centrosome malfunction, meiotic spindle disassembly. We can see that occurs, but you don't want it to be so disruptive that the poles that are supposed to be there are disrupted and the metaphase plate is disrupted. We want to prevent chromosome rearrangements. As we'll see, some of the earliest attempts with human egg cryopreservation resulted in severe aneuploidy, and we're trying to avoid that. Zona pellucida hardening is another event that is occurring with cryopreservation of the egg, and we have an easy way of overcoming that. And these other artifacts here are going to be related to some of the dysfunction in these other components. So our goal of M2 stage human egg freezing is to preserve chromosome alignment, preserve the spindle reassembly mechanisms, preserve all the gradients that the egg needs to have in its cytoplasm, and we'd like to be able to maintain zona pellucida receptivity, although, again, we have an easy way of getting around that if you don't. 2 strategies for cryopreservation essentially exist right now. One is controlled rate freezing that we're going to get into in a large amount of detail. This is involving crystallization of ice and protein matrices. In controlled rate freezing, you're going to get ice formation inside and outside the cell no matter what you do. It's a matter of how much. And then there's, of course, solidification without crystallization, and that's vitrification, something that's moving along in the front. It's emerging for human oocyte cryopreservation, and I'll touch on that at the end. Okay, we've done that. So we've been through all of that. I don't want to bore you with that one more time. So what is a controlled rate freeze like? To do a human egg freeze takes a couple of hours or more from start to finish. From the introduction of cryoprotective agents to the cell to a computer-controlled freezing mechanism. And this is a profile of a normal freezing profile that we would use for freezing human eggs and actually for freezing human embryos as well, where the eggs are introduced to the freezing unit at about room temperature. They've had cryoprotectant introduced to them. They're equilibrating with cryoprotectant. They drop down to supercooled conditions fairly rapidly, about 2 degrees per minute, to about -6 or -7 degrees. It's during this time they're supercooled and controlled this way because the cryoprotectants are keeping ice formation from occurring. You introduce extracellular ice by seeding this solution. You start ice formation outside of the cell so that ice begins to create an osmotic gradient where, as the more ice is formed, the solute concentration is increased, drawing water out of the cell and continuing on the dehydration of the process of the cell to keep water from forming in there. And the more you do this, the more water is going to come out. So essentially, in the supercooled conditions, the extracellular area starts to freeze very, very rapidly. And then we drop the temperature down very, very slowly at about 1/3 of a degree per minute to continue this process of ongoing freezing, crystallization outside the cell, and more dehydration. So essentially, the cell is really being dehydrated during the first half of this freeze here. And then everything gets essentially frozen solid and then can be plunged into liquid nitrogen after this point. Most of us plunge at around -40 straight into -196 in liquid nitrogen. That's the basic profile that most of us are using for egg freezing and has been used for quite some time. To get into the clinical side of things and how successful this has been, at least in the early phases, in 1986, the first, actually 2 groups, almost independently, had 2 pregnancies created by freezing human oocytes. Controlled rate freeze using DMSO as a cryoprotectant. Their survival rate of the eggs was not very high. I think it was 15 to 20% survival, but they had enough eggs to transfer to the patient. Patients got pregnant, had healthy babies. So it was a good start. Continuing on that, the first clinical study with a decent-sized group, 48 patients, was done. Only 2 pregnancies were created. They compared the effects of propane-diol versus DMSO as cryoprotectants. And they were the first to notice that in the human egg freezing situation, aneuploidy was very, very prevalent. These were young patients. You would not expect to see 20 to 40% aneuploidy in a young patient. And clearly the freeze-thaw process was causing some damage to the spindle, and they were not functional well enough, which is probably the reason why very few patients got pregnant. So this continued during the late 80s, and a few pregnancies occurred. Again, survival rates being very low. Fertilization rates, actually fairly surprisingly good in some of these, but the pregnancy rates being low. And this is where people launched on to the concept that, yeah, okay, you can freeze eggs, some of them survive, but it takes too many to get a pregnancy. Very few patients are going to succeed with this. And even, again, trying further refinements of the amount of cryoprotectant, the rate of controlled rate freezing and so forth, getting fairly decent survival and cleavage, but again, poor pregnancy rates. And Trounson's group showed, with some detailed analyses, that aneuploidy was a bigger problem than most people were thinking. That this was, and in his words, actually, he felt that this might be an unretrievable problem that we might not be able to get around. Same situation with other people doing experiments with mouse oocytes, finding very high increases in aneuploidy, and it was kind of depressing. And so human oocyte freezing was not really very prevalent in the 1980s or early 90s. Several people, going back to the concept of what do we freeze, germinal vesicle stage oocyte versus M2 phase oocytes, several experiments showed that clearly germinal vesicle stage oocytes had a much higher freeze-thaw survival than metaphase 2. And Tom Toth in this area showed wonderfully that you could get good survival with GV stage freezing, and depending on the conditions, you might even get decent maturation to M2. But that's been the issue, is the consistent maturation of these germinal vesicle stage oocytes to M2. Same situation here. What happened is in Tom's lab, he was getting tremendous maturation now from frozen eggs from frozen state to thawed state to back up to M2. But what he found is that his ability for these eggs to develop to the blastocyst was extremely compromised. And this was the same situation with his unfrozen controls, indicating that the maturation situation was not optimal. He could get them frozen and thawed probably just fine, but getting them matured to M2 was a problem, and so development was a problem. So further refinements, I won't spend a lot of time on these. Basically, it was working with ratios of cryoprotectant, type of cryoprotectant, the addition of external sucrose in the mix as well to cause a change in the osmotic gradient, and try to perfect the survival rate of these situations. Is it better to freeze with and without the cumulus? And so, small refinements taking place here. Even at this time, however, the pregnancy rates were extremely low still. And, okay, we'll go past that. Other individuals are trying to look at the delicate balance of how you go through the controlled rate freeze. In other words, how you control the amount of intercellular ice formation. What temperature should you do your seeding at? What type of supercooled conditions should you work with to get intercellular ice formation? And this type of experiment was worked on for a very long time. Slow but sure, and it's very difficult working with human oocytes because you don't get many to work on. So these experiments are done very few and far between to try to come up with the optimal cryoprotectant, the optimal seeding temperature, the optimal freezing rate, and so forth to give you good viable cells. And so if you take a look at a quick compilation of data from the late 80s up through currently, you'll notice that the survival rates were very, very modest in the early phase. And currently, all of a sudden, survival rates have been improving. dramatically improving. And it has to do with some very subtle changes that people have found in the recipe for controlled rate freezing. And I put this in here because the driving force for actually the success that we're seeing with the human egg freezing comes out of Italy and with politics in Italy. A lot of people think that IVF was born in the UK, and it was. The first baby was born in England. However, IVF in its modern sense with controlled stimulations, more eggs, multiple eggs produced, et cetera, actually was created in Italy. And Italy has been in the forefront of IVF technology for a very long time. But the politics in Italy are such that over the last few years, it was very clear that due to sensitivities of extra-human embryos being created in IVF laboratories and extra-human embryos being frozen, the political factions in Italy did not want that to occur. And the practitioners in Italy knew that there was going to be a time when human embryo freezing in Italy was going to be prevented. And so that stimulated a lot of activity on part of the clinics in Italy to perfect egg freezing. If during a given stimulation you could freeze most of the eggs for a patient, inseminate only 3, which is what was going to be required, you could solve the legislation that was going to come down, while at the same time giving the patient multiple chances of perhaps getting pregnant with one hyperstimulation. So the Italians, led by Porcu and Fabri, started working very, very hard with egg freezing technology. And they started out using some of the same recipes that I just showed you from some of the earlier experiments. And they had the same kind of frustrating results: low survival rates, low pregnancy rates. But they did have the first birth of human oocyte from human oocyte freezing and using ICSI for fertilization. They realized that the zona pellucida was disrupted significantly in their hands, and so they had to overcome that by using microinjection techniques. So they thaw their eggs out. Those that survived, they use ICSI to fertilize them, and so they had the first frozen egg ICSI birth. Consequently, they started tweaking their protocol. Simple changes in the recipe to improve survival rates. At this point, routinely coming up to 60% survival rates. Very high rates of cleavage. The embryos were relatively healthy of those that got fertilized. And pregnancy rates started to come up. 13% pregnancy rates don't sound like very much, but when you're dealing with a 2 to 3% pregnancy rate prior to that, this sounds pretty good. And so they started moving even further and came up with a very subtle change in their recipe by adding 0.3 molar sucrose to their freezing gamish, changing the length of time that the eggs were going to be in cryoprotectant, extending this period of time of equilibrium that the eggs were going to be seeing the cryoprotectant before they reached seeding temperature, and reached survival rates that were routinely up in the 80s. Consequently, from basically the creation of this particular recipe right here and some other changes around the world, there right now have been about 150 live births from frozen eggs currently around the world. The vast majority of these are from Italy. Probably about 100 of these have come from Italy. And it's because they now are legislatively restricted to only inseminating 3 eggs at a time. So they're doing a lot of egg freezing. And if you look at some of the summary of data that has come out of egg freezing technology, a lot of people are summarizing data from the early 80s and lumping that with data that is current and giving you the same kind of results. Oh, you need 100 eggs to get 2, and so forth. And that actually is not true anymore. You can get a far more efficient survival and pregnancy rate now. The Italians are achieving now about a 25% pregnancy rate with their freezing process, and that is nearly on a par with their fresh IVF cycles. And so something clearly has changed here to improve the efficacy of this. Changes in this, at the same time the Italians came out with some of their changes in the recipe, people have been starting to play a little bit with sodium depleted medium, basically choline substituted media. And there's some clinical trials now going on with Jeff Bolt's laboratory showing great survival and a definite increase in pregnancy rates. At the time of this publication in 2003, the 5 kids had been born. They now have, I believe, 25 born. And this recipe may be a common one that we might all want to try. And here in the Boston area, Tom Toth's laboratory is playing with the concept that Mother Nature has come up with, basically the presence of large molecular weight sugars inside the cell. And so they're playing with trehalose microinjection into these eggs prior to freezing, getting very nice freeze-thaw survival rates. And they currently have an ongoing clinical trial using 20 egg donors, I believe. And I look forward to hearing the results from that to see how effective that might be. So let's take it out of just to kind of give you a little bit of kind of a warm fuzzy on this about egg freezing and give you a description of one clinical case that happened to us relatively recently that really threw us into this clinical realm of egg freezing. We had a 32-year-old IVF patient came to us. She had tubal disease, very simple IVF case. The day before her egg retrieval, her husband had a ruptured appendix, and was in the ICU. And so on the day of her egg retrieval, it was a bit contraindicated to get sperm from him. And he was very, very sick. And, here she is. This couple had invested a lot of emotion and a lot of money and a lot of time in getting to this point, and we had no sperm. And they didn't want to use donor sperm. They weren't prepared to do that or whatever. And I had been playing with the Italians' freeze-thaw recipe in research. And so I called up the Porcu group that morning that we were in trouble here and asked Eleonora whether they had made any further changes that hadn't been published. And she goes, "Oh, Professor Battaglia, it's so nice to hear from you." And I'd met her before, and she goes, "No, you will like that recipe very much, and you really should learn to speak Italian, and we can speak more about this." And so it was wonderful. She gave me a few more tips, and so we offered this to the patient, and she, of course, took it. And this is extremely experimental. We didn't even have an IRB approval for this particular case, but she had 20 eggs, and I used Porcu and Febreze protocol. They came back to us 3 months later. My survival rate post-thaw was not as good as what the Italians had done. Was half of them survived. Of those, 9 of the 10 fertilized were M2 phase. 8 of the 9 fertilized with ICSI. We transferred 3 embryos, which is unusual for us. We usually only transfer 2. And we transferred 3 just because of the pregnancy rate with freezing being a little bit lower. And she initially showed up with a twin pregnancy. It spontaneously reduced to a singleton. And I would like to introduce you to the first frozen egg birth on the West Coast. Actually, little Adrian here has been quite the talk of Portland in particular. His parents are so absolutely astonished that this worked. And what's interesting is they're no more astonished than I am. It was one of those things, you play with things in research, and that's all fine. It's kind of an ethereal world, but you're out there all of a sudden in the real world trying to apply this to a clinical case to help somebody out, and it works. I mean, it's absolutely astounding. So it really makes you feel good to come to work when you see a little guy like that. Okay, so we've talked about controlled rate freezing, crystallization of ice, and controlled rate freezing. The other issue is the use of vitrification for freezing eggs. And the egg, considering its size and complexity, might be amenable to that. If you take a look at the difference in the freezing structure between controlled rate freezing versus vitrification, it's very, very different. If you control rate freeze a solution with proteins and water and so forth, you get ice crystals. It's expected. If under the right conditions you take that same protein matrix, water, protein, salts, and so forth, put in the appropriate cryoprotectant, and flash freeze it in liquid nitrogen, this is solid frozen here, but there are no ice crystals present there because of the ratio of cryoprotectant to the water that's present and so forth, and the rapidity of the freeze and so forth. So it turns into a very much different circumstance. If you can prevent ice formation, some of the consequences of freezer burn damage could be prevented theoretically. So people, even at the same time that the protocols for controlled rate freezing were coming about, people were trying vitrification using mouse oocytes, getting tremendous survival under various conditions, decent cleavage rate, 25% pregnancy rate with their mice, great blastocyst formation. So some of these earlier recipes actually were showing up to be pretty good. Same thing with using the cow. And the cow is a good model because the cow oocyte is closer in function to the human than the mouse. The mouse is not a very good model for the human oocyte. The bovine or even the sea urchin actually are closer. And so they're working with little apparatuses, different types of structures to freeze these eggs in. up until this point, people had been putting eggs in a regular straw that holds about a quarter of a cc of fluid, throw in several eggs, dunk that in liquid nitrogen, and get it to freeze. And you'd think that would freeze fairly rapidly in liquid nitrogen, and it does. But if you take that structure and you actually stretch it under heat so that it's even a finer needle, much smaller volume, greater surface to volume ratio, you can freeze these cells at 20,000 degrees per minute by dunking them in liquid nitrogen. And that's the key to successful vitrification. It's the rapidity of this freeze. On the human side, the first birth came in 1999 using vitrified oocytes. The open pulled straw method was used there. Again, as I tell you, they pull these straws out into a very thin needle-like thing. But they're putting these cells in a very toxic gemisch of cryoprotectant, 40% ethylene glycol, high-level sucrose. But their survival rates have been good. Fertilization rate has been okay. And from the 4 patients they tried, they had the first birth. Not bad. A recent paper just came out and shows a different type of apparatus, which is very clever in itself. It's a polyethylene ribbon, actually. The oocyte is put onto the tip of that ribbon with 1/10 of a microliter of fluid. And this structure is dunked into liquid nitrogen and put into a protective cap so that they can be stored and so forth. And using this apparatus, they found that the rate of cooling was maximized by doing this because there's very small volume to be worked with. And on the other side of the coin that addresses your question, if you can warm them up rapidly, your chance of ice formation during the warming process is decreased. So if you have a rapid cooling and a rapid warming, you can prevent some of the ice damage problems from occurring with this little cryotop device. Going down to the punchline on this, there have been now 7 deliveries for patients out of 29. There've been, let's back up here. 41% pregnancies out of 29 embryo transfers, 7 live births, and they currently have 3 ongoing deliveries going on, and the trial numbers are increasing with this. So it could be possible that vitrification is going to overtake controlled rate freezing in terms of its viability to successfully obtaining eggs in cryo storage. So, are we ready for egg banking? I say a qualified yes. I think under appropriate conditions, if you have experience with this, yes, you perhaps can do this. Should this be offered to any patient that comes along yet? No, I don't think so. I don't think that we're necessarily offering an ethical choice to a 25-year-old patient who says, I'm going to spend $10,000 to have you freeze my eggs today, and I'll come back when I'm 40 and use them to have my children. I don't know if we can offer her a very decent chance of success yet. However, I'd predict in a very, very few years that we will be able to do that, and egg freezing will be able to be commonly utilized. So that was what I had to say about the strange world of egg freezing, and I'm willing to take on any questions if anybody has any.
Thanks very much, David. That's a lot more promising than mine was earlier. Are there any questions now? If you guys have a couple.
Any biochemical measurements in those eggs after freezing so far?
There have been some metabolic studies done to look at mitochondrial damage and so forth. Those look promising as well. It's difficult to know what are we going to look at. If you have ideas on what to look at, I'm all ears. What indicator might be helpful to know whether or not that egg truly is healthy and not sickened by the trip through liquid nitrogen.
Has anybody looked at aneuploidy rates after vitrification?
Yes, I haven't seen any publication on it yet. The Koreans actually have done some, and it looks actually better than what we've seen with controlled rate. Again, another piece of the puzzle looking promising.
You said that if the chromosomes have a particular orientation on them.
That's our belief. That's a theory that we haven't been able to prove yet. I wish we could.
Okay. I know that Pat has similar notions.
Pat and I worked on that.
After the first after second meiotic metaphase takes place, and now you have a haploid nucleus, is there evidence that the orientation among those chromosomes in some ways is preserved through the first cycle, because that haploid group is now going to duplicate,
Right.
and you have old chromosomes and in essence new chromosomes.
I have not seen a detailed analysis done on that, which would be very useful to know. People like Pat would be tremendous in deciphering that particular issue and look at the nitty-gritty of the molecular basis of the metaphase plate under these conditions, but I have not seen any data on that.
Are there more successful pregnancies from oocytes from young women?
Yes, almost all of these have been from younger women, and in our hands, some of the preliminary experiments we have done, the disruption of the meiotic spindle in the older oocyte is much more dramatic. And that, actually, it's hard to tell. If you look at the oocyte spindle structure in older women, it's already a problem even before you try to freeze it. And
So we're not going to offer this to the woman who gets to be 39
No.
and says, it's now or never.
It's probably too late.
That it's going to have, so we're looking at really offering that 25-year-old at some point.
That's right.
Yeah.
That's right. Age is everything.
Thanks a lot, David. We're going to take a 2-minute break.